Hello, everyone. Welcome to the Brown Surgery Podcast. I'm your host, Kenneth Lynch. For those of you that do not know me, I'm a PhD educator and nurse practitioner by training. The focus of this podcast is to span both clinical and educational fundamentals and turn everyday topics into interesting discussions that can benefit students, residents, and faculty alike. Today, we're going to kick off a two-part series on the role of the surgical scientist and what that looks like today. I thought it would be good to get two different perspectives from our local faculty here at Brown to talk about their experience with choosing this career path. To start us off this week, I'd like to welcome Dr. Daithi Heffernan to the podcast. Daithi is an associate professor of surgery and one of our trauma critical care surgeons here at Brown. He has been with us since completing his surgical critical care fellowship at Vanderbilt in 2007. Since that time, he has had a very productive clinical and research career with us. His current research is primarily focused on INKT cells in critical illness, trauma, and infection. In 2011, he was awarded the Shock Society Junior Faculty Grant, as well as a Serdna Fellowship through Brown University's Center for Gerontology and Healthcare Research. He also received a K Award in 2015 to look at the role sepsis plays on INKT cells and their effect on phagocyte function. Because of his practice and career journey, which is a little atypical from the standard track most of our residents take, I thought it would be a good idea to bring him on today to talk about why he ultimately decided to become involved in surgical research and how he currently balances a busy clinical practice along with family life and a productive research career. Welcome, Dr. Heffernan. Thanks for being here today.
Hi, thank you. Thank you for having me.
I guess just starting out, can you tell us a little bit more about how you ultimately became interested in surgical research?
Yeah, sure. I've always been interested in asking the question, why? I've always been interested in some level of research from early age, which I guess brought me to science. Surgical research specifically, because I always like asking the question, either how do we fix, change, go forward, improve, or asking questions, why? Why does this happen? And sepsis has been certainly the area, sepsis, trauma, critical illness, been the area, because I feel as though that is an area that is very much unexplored, and between high mortality rates, high critical illness, long-term outcomes are affected, and trying to get to an answer to make patient outcomes better in a meaningful fashion is really what drives me to think through these questions every day.
And your journey to becoming a surgical researcher might be a little bit different than the ones we're familiar with. The residents take a couple of years out of their clinical practice and go into the lab. Can you talk to us about your journey?
Yeah, I'm certainly not a typical journey at all. As many of you guys know, I'm Irish, born, bred, and raised. And one of the struggles I realized early on in Ireland was there's very, very limited resources to actually undertake research in Ireland. I was very much inspired by a researcher at Trinity College Dublin who discovered the gene for retinitis pigmentosa in his lifetime, which is now a curable disease. It went from 100% incurability to almost 100% curable now because of what he did. So I thought I could do that sort of stuff, but as a medical student, I quickly realized that there are a lot of barriers to it. And I was advised, well, if you really want to do that, don't go into medicine, do science, do a PhD. And so I learned tricks and techniques from that in terms of the first most important questions to ask. What are you interested in? What drives you? What question would you like to solve? And you don't have to you don't have to get an answer overnight. It's important to understand that research is in for the long haul. You're not going to suddenly get your answer in one weekend or 1 week or 1 month or even 1 year in the lab. And so I found mentors and I found folks who were willing to take me on nights and weekends. It meant some busy weekends and meant turning up on Saturday morning at 7 o'clock and being prepared to go till Sunday evening. I will never forget looking down microscopes at 2 a.m, counting blue and brown dots, trying to determine Ki-67 proliferative indexes in gastric carcinoma. But that's what made my move forward. It was also important at that stage to identify chunks of data that I could actually manage. Don't try and answer a huge, big question, but take a portion of it. I was very fortunate then when I came to America. I took a year translation where I worked in the Department of Surgery under Nancy Asher and the transplant folks, and worked with some great hepatologists and gastroenterologists. And again, I just signed up to be a lab tech, but I learned a lot of experience there in terms of how you answer small pieces of question. But the fascinating part that I realized was that as a clinician, we have a skill set that the basic scientists may not have in terms of we can apply this clinically. So sitting in grand rounds, my mentor at the time, we were talking about outcomes for patients who'd had transplants. My mentor at the time leaned over and said, I don't have time, but can you look that up, grab 100 charts, and we'll get a question. So being a clinician, I could answer that question. That was my first presentation in the United States. And then coming to Albuquerque, and that's a whole other question, why Albuquerque versus my second choice, University of Chicago, where I was going to be offered a 2-year spot in the lab. Albuquerque was very clinically busy, and I knew that as a researcher, you have to be able to take care of patients. At the end of the day, it doesn't matter how many genes you've cured or whatnot. If a patient comes in bleeding or perforated something, or even just a hernia, if you can't fix it, you're not very good for that patient. So a good clinical basis was critical. However, again, it struggled with the idea of how do I get research done? So the number one is just knocking a lot of doors, just ask and ask and ask and ask. And then be prepared to answer a lot of clinical questions, such as the role of endovascular stenting in traumatic aortic dissections. Also, clinical outcomes such as race and inequity was a big thing I studied. And then my first interaction was with mentor Tom Howdyshell. Dr. Howdyshell was running a pig lab in Georgia before he came to Albuquerque, looking at the role of VEGF and nitric oxide in wound healing. So again, that was a case of I knew I wanted to do something. We knew we had limited time, but he was able to set up portions of experiments where Friday evening or a weekend when I was not on call, he'd set it up. He said, okay, I want you to do that and have it done by Monday morning. And having a mentor who can realize or recognize how to set up a portion that's doable at night or on a weekend, and you can do that now. A lot of that changed. My daughter was born in 2003, and that kind of changed how I was able to produce things. This was obviously before I had the children. But it's that idea of finding someone who's willing to say, yes, I get we don't have time to sit 2 years in the lab and spend hours and hours, but have portions, either run a Western or do flow cytometry or do something like immunohistochemistry. That might be a 3 or a 4 hour period, but you can set it. And then having a lab where there are collaborators who can help you start something or can finish off something so you can have a meaningful portion of it.
Yeah, I think that's important because I think people struggle with what they're going to do for the rest of their life, and some feel like they're forced to make a decision to go into the lab after 2 or 3 years of clinical practice. And I think you're a great example that just because you didn't do 2 years in the lab during your residency, that you can still have a life in research if you want to go that route. I guess just branching off of that, for someone maybe who didn't go into the lab but wants to get into research, what available resources are there for residents or surgeons, junior surgeons who want to get involved in research, learning how to write IRBs, grant writing, and getting funding for a project they want to get off the ground?
Well, the biggest resource is the faculty around you. Finding someone who's willing to spend some time to ask and answer a question with you. As faculty coming here, one of the things I was able to demonstrate was an ability to write, produce paper, be productive. And that's very, very important. If you come from a residency and your chairperson signs off and says, yes, you can tie a knot and you're clinically competent enough, that shows you're clinically capable, and then you want to be able to demonstrate you can do something above and beyond it. So again, it's not all about doing the basic science. There are a lot of clinical questions that are out there, and being able to say, here is a product. I started with a question. So here at Brown, I think one of the untapped talents that we have are the fantastic faculty who themselves have questions, but may not have the time or the resources to ask it, or they themselves are asking other questions and they just don't have time to finish the million ones. The greatest example of that I think is still kind of amusing is the paper myself and Dr. Monahan wrote on the role of urinary tract infection in trauma patients. We had been sitting talking with the gerontologists and listening to how a UTI affects patients differently and the role that has in altered mental status and why it was such an important thing. And we argued the debate about whether or not you base it on clinical symptoms or culture data. But ultimately, the medicine folks believe that UTIs in geriatric patients leads to mortality. You ask the question why. So the next question was, well, can we see that in trauma patients? And we simply just took the trauma data set. So again, that's a resource that's available here. The data's already collected. So most of the hard slog work is already done. Looked at patients who were given a trauma, whether they had urinary tract infection, isolated the geriatric patients, and demonstrated that UTIs had an increased risk of mortality. Now, there were many cynics who thought this can't be a real value, but again, we had appropriate statistics, we had the backing in geriatrics, we had a good question and a simple binary association. We never demonstrated cause, we saw the association. And it was a willingness for faculty to sit back and just say, go ahead and answer that. Even if, and sometimes it's also helpful if the faculty has a sense of what the answer should be, because then we know what direction this is going. So for residents here, I think it's very important to find someone with whom you have rapport, for whatever reason or however that can be, and start to ask questions. And sometimes the faculty may not know how to go about analyzing data or collecting data, and so there's plenty of resources in the department themselves who can help either write an IRB or put together an Excel spreadsheet.
Yeah, and even going further, what would you say for those who aspire to obtain a K award such as yourself? What does that process look like?
Okay, so that's how you can demonstrate your willingness to, or your ability to put together a coherent question and answer. So it doesn't have to be the basic science question. One of the pieces of work I loved most over the years here has been the micro tweet. Jeremy Dresler put that together, and people initially downplayed the significance of it, but it asked and answered a question. So if you are inclined to think in terms of lab time or basic science time or benchtop research, to ask a more mechanistic question as opposed to a pure clinically directed question, then certainly you would take time to go to the lab. One of the benefits of a K award or a Mentored award or the Shock Society award is that you learn to put together a committee, you learn to put together people who are going to review your stuff. We do this very well as clinicians, whether it's abstract review or mock oral boards, and think from the same fashion as that. You wouldn't go through residency without ever being questioned or asked or critiqued. In the same fashion, you wouldn't put a research career in the same fashion. At the end of a case, there's feedback. Well, at the end of your presentation in basic science, there's feedback. And so the first big question is identify people in the lab, or if you're looking for a faculty position, who is around that has done this, has a track record. It does not necessarily need to be someone in a department of surgery, but you should have some connection with a department of surgery, someone who knows what it takes to be a surgeon and hold you accountable. So the first big question is there an area of research that has similar interest to what you're looking at? Cancer, sepsis, wound healing, vascular growth, whatever. Second question is, do they have facilities to put together a committee? And preferably some clinician who does basic science and someone of PhD non-clinician who can formulate a question. And then within the bigger context of what they've got. For a K award, there's three parts that they look at and you're judged on. One is your science. The second is you as the individual. And the third is the environment. The science is actually the lowest of the three that are significant. So people get intimidated by thinking, I have to have this great question, this great science. And realistically, the NIH wants to know, if we hand you a bunch of money or time and resources, can you be productive out of that? So your track record in residency and potentially fellowship is helpful. And then if you do anything in your first couple of years as faculty, that's also helpful to continue to demonstrate that you can ask and answer a question and write papers. Preferably something along the field, which is why the urinary tract infection paper helped a lot with other things to show that we could show a direct clinical correlation with sepsis. One of the other projects I did here early on was to isolate blood from trauma patients and look at the role of T cells in sepsis, T cells in trauma. One of the frustrating questions that is posed nationally is, what is the role of lymphocytes in critical illness? Aren't lymphocytes just an acquired cell? So to be able to demonstrate the models that Dr. Halla was using in the lab could actually truly be related to patients made a huge difference. So that was probably the single most important part of the science. This is translatable. This could potentially move to humans at some point. The second part then is yourself. What's your background? What have you done so far? Have you written papers? Have you gotten one or two first authors in something? And although for a K they say you don't need preliminary data, the idea that you write something is kind of like your preliminary data. And then the third is your committee. Who did you put together? Have they been successful? Have they mentored someone in the past? And it doesn't have to necessarily be a surgeon they've mentored. It can be anybody. So that portion that is written by your committee says, we know how to take someone from start to end and translate and be successful. So they're the three important things when you're looking for something. When I was looking for a faculty position, there was a place at which I interviewed which said I could be offered potentially to run surgical research in 3 years. They had no surgical research. They had they really did not have a division of mentoring, and they wanted to start that. Well, if someone's starting fresh out of fellowship, that's not the right move to make, because you need to have mentorship. You need to have someone who's going to show you how not to fail, more so than just succeed. So when you're looking for that job, where's that environment? Where are those people? Have they done it before? And are they supportive?
That's great advice. And I just want to switch gears a little bit, just because you have been so successful in both clinical practice and research. Can you just explain what your day-to-day practice looks like currently and how you balance that with your career and family?
I think that's probably the most important question. That part at the end, how do you balance career and family, is the one question that you'll hear me say all the time, anyone asks for advice. I asked a question of my chairman, Dr. Fry, when I was a resident. I'm like, how to be like you? How do I be successful? And anyone who knows Dr. Fry knows his personality, so I won't try and repeat it. But he said to me, there are three things in the life of a surgeon: family, research, and clinical endeavors. So three things in the life of an academic surgeon: research, clinical, and family. And the old model of this triple threat, and you have to be perfect, was you operated all day and clinical all day, and then you also balanced research in the lab. And your family was something you were lucky to have, maybe, and you saw them on weekends. And so the model was, there are only two things you can be good at: so clinical, research, and family. And since if you want to be academics, you have to spend your time doing clinical and research, your family came second. That was the old model. So Dr. Fry clearly said to me, it was one thing that he really wanted to change as surgical training, surgical life changed as he was a chair. So he said, family comes first. Family always must come first. And since families come first, you have to decide, are you going to be the person who does 1,000 cases, or are you the person who does the research? And that was a very formative phase, because I was very much felt I have to be 100% clinical and 100% research, and maybe I might get lucky with family. The last couple of years of my residency, he was very formative in showing me how they get that. There was also faculty around who had family, and I was able to learn from them how they balance and what you need to give up. Coming here to Brown, I had very similar conversations with Dr. Jaffe and Dr. Tracy, the former vice chair of surgery here, who also stressed family is very important. Family comes first. And you need to decide, are you going to be very heavy clinical, or are you going to make research your priority, and maybe not the person who's always the go-to for the complicated fistula, the multiple cases. And so balancing that, it's a very important aspect. You have to be a clinically competent surgeon. You have to be able to take care of patients. That's number one. A patient has a complication, doesn't care if you've written 15 papers or 1,000 papers. So that's very, very important. So my life kind of now consists of having blocked time for here's lab time, here is clinic time, here is operating room time. It's very, very important not to let research roll into clinical time. If you're operating, you're operating. Don't walk away from the clinic. Don't walk away from the OR. Make sure you round. Make sure you see patients. But then have time blocked out. The other piece of advice I got early on was to those early hours in the morning when the rest of the world seems to be waking up, maybe have that for your writing time, or block out time where you're just going to sit in front of a computer and write the paper, write the RB, write the INKT, whatever it happens to be. If you're working with a resident or a medical student, make sure you give time to help write their papers. I've not always been the best at that. I've not been the most successful, but that's certainly a way to go forward. So think family first, and then after that, you're going to decide, are you going to have a clinical heavy life or a research heavy life? And research can be anything. Research can be education. It can be asking questions in terms of score, absites, or it can be clinical research, or it can be bench research. But you need to really try and balance those two. And the best way I've found is try and block out time. This day is for research. This day is for clinic. Don't try and plan your lab experiments or writing IRBs if you have clinic. That's your commitment. You turn up. But after that, maybe at 5 o'clock, 6 o'clock in the evening.
What would you say those people say you can't be great at all three? You can't be a great father. You can't be a great researcher. You can't be a great clinician at the same time. One of them has to give.
Yes and no. I do agree with that, but it's not quite the way I would phrase it.
Yeah.
The triple threat used to be considered within one person. Most departments are now trying to build within divisions a triple threat within the division. There's someone who is that great clinician who will, who will do extra cases. There's someone who is the administrator. There's someone who is the educator. There's someone who is the researcher. I think you need to look around at your partners. What do they value? How do they value things? I've been extremely lucky and blessed with the partners I've had over the years. They have valued family. They have realized that it's important to get home, to see kids. So yes, the department in which you're in has to be the triple threat, or it needs to be good at all three. For the individual, it comes back to, again, do you have solid training? Have you had a good fellowship if it's necessary? Do you have supportive partners who can help you with difficult cases? Do you know what you're capable of doing? Do you continue to do difficult cases or do appropriate cases? But you don't have to be operating every day, clinic every day. And if you're not, then yes, you might be the person who's known for education, the program director. You might be the person known for clinical research or the basic science research. And then hopefully there are people in the division who are known for productive clinical activity.
If you had to give some words of wisdom or encouragement to residents who are struggling with the decision as to whether or not they should go into the lab, obviously folks do it for different reasons, whether it's for, to try to obtain a fellowship that they want or professional development purposes. If you were talking to one of them now who is on the fence about doing it, what would you say?
Yeah, the biggest piece of advice I would give any resident is follow your heart. Why are you thinking about it? What is leading you to consider life in this area? Research can be very exciting. You don't have to do time in the lab to have a good research or academic career. It's not essential. Unfortunately, I'm not sure how to answer the question about those for whom research is an essential tick box to getting certain fellowships. That's hard. But we have had residents successfully get to those difficult fellowships, ped surgery, surgical oncology, without doing time in the lab. I think you need to start making those decisions as a second year fairly early on, because if you're deciding not to do 2 years in the lab, there are other ways to build a CV, to build a resume that will be appealing to a fellowship. There are a lot of clinical papers that can be written. There are meetings you can get to. There are meaningful clinical questions that can be answered. There are a lot of faculty here at Brown who will be happy to have a resident work on something. So it's not an essential. For a lot of fellowships, it's certainly not an essential component. If you're on the fence, make sure you have something so when you hit a fourth or fifth year position, you're trying to apply, you're not looking back regretting you wish you did something. And it's surprising. The amount of clinical questions that can get asked here at Brown is tremendous. So if you're thinking about it, start with a clinical question. If you are going to a lab, find a mentor who understands what it means to be a surgeon in a lab. Again, you want to be careful that you don't go on the 9-year track. Some folks, say in postgrad, PhD, they have 5, 6, 7, 8 years. There was a student here some years ago who took 8 years to complete her PhD. And it's fantastic, incredible work, great science. But as a surgeon, you don't have 8 years. You have 2 years in the labs. You need to have someone who understands that time commitment and help you be productive. But again, if you're on the fence, find someone in your area, surgical oncology or ped surgery, who's willing to work on clinical projects with you and knows, again, how to get that completed. So when you hit fourth year and you're thinking of applying for a fellowship, you have a CV that has enough entities to say, I'm capable of doing this and I truly have an ongoing interest.
Thank you very much for your time. I think this is great advice for residents out there who are thinking about this or contemplating a career in research. So I appreciate all this discussion and your advice to them, and I think they'll get a lot out of it.
Great. Thank you very much.
This concludes part 1 of our discussion on the role of the surgical scientist. I'd like to thank Dr. Heffernan again for providing us with this insight and his experience in this career track. Stay tuned next week where we continue this discussion and speak with Dr. Sean Monahan about his experience, particularly why he decided to enter the lab as a resident, his experience as a researcher, and how he balances his unique role here in our department. In the coming weeks, we will continue our discussions around research, specifically about using mortality as an outcomes variable. Our Chief podcast project also kicks off in April, which we are really excited about, so stay tuned for those, and I'm looking forward to having you back with us in the next episode.